ध्वनिर्वर्णा पदं वाक्यमित्यास्पद चतुष्टयम् यस्याः सूक्ष्मादि भेदे वाग्देवीं तामुपास्महे।
The Electronic Media Production and Research Center EMPRC of Madhya Pradesh Bhoj Open University presents an audio program on visual impairment. This audio program will be useful to the students of B.Ed Special Education Program. The title of audio program is Community-Based Rehabilitation for Persons with Visual Impairment. To deliver the lecture on this topic, we have invited our subject expert, Dr. Nora Griffing Shirley. She is a professor in the program of Special Education at Texas Tech University in Lubbock, Texas, in the United States of America. This audio program is recorded, edited, and presented by Amar Bahadur Yadav. Now let us listen to the audio program Community-Based Rehabilitation for Persons with Visual Impairment.
Hello, dear listeners. I am a professor in the Special Education Program at the Department of Educational Psychology and Leadership in the College of Education at Texas Tech University, which is located in Lubbock, Texas, in the United States. In addition, I also coordinate the Orientation and Mobility Specialist Program, and I am the director of the Virginia Murray Sowell Center for Research and Education in Visual Impairment. I have been teaching in a university system for over 20 years. I would like to thank MPBOU Open University for this opportunity to speak to you today about rehabilitation services for individuals with visual impairment. Rehabilitation services are delivered through center-based programs and community-based programs. This lecture is about community-based rehabilitation. The topic of center-based rehabilitation programs for persons with visual impairment will be delivered in a subsequent program. Questions you may ponder on when thinking about community-based rehabilitation include: what is community-based rehabilitation? What services are provided through community-based rehabilitation? What are the advantages and disadvantages of community-based rehabilitation? What role, if any, do I, as a teacher of students with visual impairment, play in the community-based rehabilitation process? The vocabulary for today's lecture includes: number 1, rehabilitation. Rehabilitation is a training program provided to persons with visual impairment, aiming at ensuring skill enhancement, independence, self-reliance, self-confidence, complete integration, and empowerment of the individual, as defined by Panini, Rawal, and Sajic in their book, Manual Community-Based Rehabilitation. 2. Community-based rehabilitation is a goal-oriented, need-based, cost-effective, and result-oriented strategy of providing time-bound and appropriate services within the community, with its active participation, involvement, and with fullest use of its resources. Community-based rehabilitation aims at integration of the individual in community life. It ensures community support to protection of human rights, equal participation, equity, social justice, and complete development of the individual, as defined by Panini, Rawal, and Sajid in Manual Community-Based Rehabilitation. 3. Client. The client is a person with a visual impairment who is receiving training in rehabilitation. The objectives for today's lecture are 1. To define rehabilitation and community-based rehabilitation. 2. To describe the history, the characteristics, the components, and the services of community rehabilitation programs. 3. To identify the advantages and challenges faced by the rehabilitation field in the provision of services to people with visual impairments. 4. To discuss the role of the rehabilitation workers and the education professional when rehabilitation services are provided. And 5. To identify evaluation indicators to judge the success of a community rehabilitation program. Various definitions of rehabilitation exist, but I am choosing to use the definition by Panini, Rawal, and Sajid in the book Manual Community-Based Rehabilitation, which states, rehabilitation is a training program provided to persons with visual impairment, aiming at ensuring skill enhancement, independence, self-reliance, self-confidence, complete integration, and empowerment of the individual. Dr. Trilokesh Chakraborty, in his essay, Vocational Training and Rehabilitation of the Visually Handicapped Persons, found in the Golden Jubilee Celebration, 1967 to 2007, published on January 18, 2007, by the Ramakrishna Mission Ashrama, discusses that rehabilitation of individuals with visual impairment includes the following precepts. The individual with visual impairment need to live socially useful and meaningful lives by performing the expected social functions of all people, being active contributors to their families and communities. Training should be strength-based rather than deficit-based, focusing on the strengths of the person with a visual impairment. What can the person do, not what cannot the person do, should be the primary concern of a rehabilitation training program. Appropriate therapeutic treatment and advancement of rehabilitation technology can mitigate the degree of loss of capability down to 40%. People with visual impairments are usually underemployed. In India, most schools for the blind do not have adequate curriculums to ensure students are vocationally trained and ready for the job market. The author goes on to explain all curricula needs to focus on the current job market, which involves computer skills and salesmanship. He uses the phrase economic rehabilitation, stressing the need for the vision field professionals to shift their thinking to this concept. A community-based rehabilitation program is concerned with total rehabilitation by using community resources. What do we know about the demographics concerning Indians with visual impairment that necessitates the model? We know that most people with visual impairment are living in rural areas, are older, and are women. We also know the leading causes of blindness in India are cataracts, trachoma, and vitamin A deficiency. Rehabilitation centers are few in numbers, expensive to operate, and are usually located in urban areas, thus not meeting the needs of the majority of adults with visual impairment who reside in rural areas in India. In fact, residential schools for the blind only educate 25,000 students, while only 12,000 are being educated in the public school sector through an inclusive model, while the rehabilitation centers are servicing 8,000 people. In other words, many people with visual impairment do not have access to ophthalmological care, rehabilitation services, and support services. Panini and Raul in the Visual Impairment Handbook feel a community rehabilitation program is a viable solution to the mentioned situation. Suggested prerequisite skills for students to gain prior to their involvement in a rehabilitation program are stimulation, daily living skills, sensory training, orientation and mobility, communication skills and language development, memory building, basic education, and vocational skills. Each prerequisite skill will be discussed briefly. Stimulation can be thought of as early intervention services where parents are taught how to care for and interact with their infant and preschooler who has a vision loss. Parents should try to expose their young children to many different events, places, and activities. Daily living skills are the tasks most individuals accomplish on a daily basis. These tasks include bathing, dressing, feeding, toileting, and house cleaning, to name a few. Sighted children watch their parents and siblings complete these tasks, and then they imitate them through play. Children with visual impairment have to be taught these skills using a hand-under-hand approach and task analysis. Sensory training focuses on teaching children with visual impairment how to utilize their senses to their maximal extent possible. Rehabilitation workers and early intervention specialists can guide parents how to teach their children to use their senses when completing everyday activities. Once in school, the classroom teacher and the teacher of students with visual impairment will also concentrate on sensory training. Orientation, knowing where you are in space, and mobility, the act of moving from one place to another, needs to be taught to children with visual impairment. An orientation and mobility specialist, and you, as a teacher of students with visual impairment, teach these techniques to these children. Adaptive equipment may be used, such as a long cane, low vision devices, or a global positioning system to map out a new route. Communication and social skills must be taught to children with visual impairments if they are going to have fulfilling long-term relationships with others. Looking at a communication partner when talking to him, using gestures appropriately, learning what different voice intonations mean is just a few of the specific communication skills that children who are blind must become adept at if they are going to be proficient communicators. Parents, teachers, and classmates can help students with blindness learn these skills by providing verbal feedback. Language development is an important skill for any child, especially for children with blindness. Parents are encouraged to talk to their children with blindness about everything: what they are doing, where they're going, why something happens, etc. It is very important, while parents are answering these questions, that they provide concrete experiences for their children to explain the various concepts being discussed. Memory building is crucial for students with visual impairment, as assistive technology is not available to every child with visual impairment in India. Activities such as memory games and memorization of selections of literature help with memory building. Basic education is essential to future employment. The more educated the person with a visual impairment is, the better are his chances at securing a good job. Vocational training should provide students with the skills which will lead to employment for them, whether they are blind or low vision. The Indian government has allotted 1% of the total job vacancy to the visually handicapped. In many cases, employers have hired people with low vision than those with total blindness, therefore reducing the number of available government jobs for persons with total blindness. Congenitally blind students may need to be taught the purpose and importance of work. To help students select a vocation they would like to prepare for, it has been recommended that the following conditions exist. 1. The student is interested in the vocation. 2. The vocation is marketable in his home area. 3. the client has the skills to perform the job, the materials to accomplish the job skills, and wants to be employed. Or a task analysis should be used when teaching job skills to students. The characteristics of community-based rehabilitation programs are centered on the integration of community-based rehabilitation services into existing networks such as healthcare, education, and developmental services. Communities assume the responsibility of making its citizens aware of people with disabilities, to access its resources, and to use them to provide services and training to the residents with visual impairment, to develop a strong referral network, and to enlist political support for community-based rehabilitation services. Community-based rehabilitation is described as a multi-sector approach using all community organizations and services. Some of these organizations, such as agricultural extension, water and sanitation programs, may not have been involved in rehabilitation prior to the community-based rehabilitation movement, but need to have involvement now for community-based rehabilitation to be successful. These programs could be future employers of people with visual impairment. It is imperative for persons with visual impairment to be actively involved in community-based rehabilitation services. They must be motivated to participate and help problem-solve situations. Family and friends are also key partners in this model, as well as other service providers. With this model, it is assumed individuals with visual impairment will remain with their families, assist with supporting their families, and function at the high level as sighted persons doing the same job in their communities. If a person has lost his sight as an adult, then with rehabilitation training, we say he should perform and function at the same level prior to his becoming visually impaired. However, if a person is born blind, then education and rehabilitation services should enable him to become an independent person who can be self-sufficient and independent in his community as any sighted community member. With a community-based rehabilitation program, the homes and communities of people with visual impairment become the rehabilitation training area. Thus, the community is involved with the development, implementation, and evaluation of rehabilitation programs for their citizens with visual impairment. According to Panani, Raoul, and Sargent in the Manual Community-Based Rehabilitation, specific components of a community rehabilitation program include covering people of all ages, be cost-effective and result-oriented, be realistic and need-based, be in consonance with state policy, include aspects of prevention and cure of curable disability, certification of incurable disability, social integration, integrated education, economic rehabilitation, support services and concessions, advocacy rights of persons with disability, acting as a pressure group for influencing state policy, community empowerment and participation, and the utilization of community resources. A change in communities' attitudes towards people with disabilities, including visual impairment, is an important outcome of a community-based rehabilitation program. To accomplish this attitudinal change, people with disabilities and non-disabled people must communicate openly and honestly with one another. The non-disabled population must recognize that people with disabilities reside in their communities, have needs that must be met through local training, and adopt the desire to integrate these people into their society. As early as the 1950s, community rehabilitation programs were advocated for by a number of organizations. For example, in 1954, the World Congress for the Welfare of the Blind passed a resolution calling for the training of people with visual impairment who resided in rural areas. In 1955, the Asian Conference on Work for the Blind also passed a resolution to train rural people using a community-based system of delivery of services, followed by the World Health Organization of 1958, suggesting that rehabilitation services become an integral component of health care services. In fact, the World Health Organization published a manual for the development of a community rehabilitation program and training of personnel to work in this system, titled Training in the Community for People with Disabilities. In 1995, at the International Council for Education of People with Visual Impairments Regional Conference, a plan of action emphasizing the need for communication between community rehabilitation programs and education developed. The United Nations also recognized community rehabilitation programs as an option for the promotion of effective and appropriate services for persons with disabilities. The history of community rehabilitation programs in India began when non-government organizations, or NGOs, recognized the role rural-based instruction played in the provision of services to reach the majority of people with visual impairment. The administrators of various non-government organizations started to implement this model in the 1980s. From this effort, the model found success both financially and politically. In 1973, in Madhya, a rural blind rehabilitation center was established with funding from the United States, while in 1983, the National Association for the Blind developed a national project titled Social and Economic Rehabilitation of the Rural Blind. The Indian government followed with subsequent legislation and financial backing through such programs as the District Blindness Control Societies, the District Rehabilitation Scheme, the Rehabilitation Council of India, the Persons with Disabilities Act, and the Community-Based Rehabilitation Scheme of the Ministry of Social Justice and Empowerment. Now let's take a few minutes to discuss what each of these agencies and laws have contributed to the community-based rehabilitation movement. The District Blindness Control Societies promoted eye care, or health of the eye. The District Rehabilitation Scheme was a funded project to provide a model for rehabilitation programming to rural individuals with visual impairment and to create a group of multidisciplinary personnel to work in this rehabilitation system. The Rehabilitation Council of India was established in 1992 to standardize the syllabi of training programs for rehabilitation personnel, to develop and maintain a database of rehabilitation workers, and to provide a continuing education program for rehabilitation workers. Currently, the Rehabilitation Council of India refers to community-based rehabilitation as community participatory rehabilitation. The Persons with Disabilities Act of 1995 called for early detection of people with disabilities, equal rights, and access to assistive technology, full participation in society, non-discrimination in transportation, research and integration of students with disabilities in regular schools. The Community-Based Rehabilitation Scheme of the Ministry of Social Justice and Empowerment appropriated monies for the hiring of rehabilitation personnel for community-based rehabilitation for the first time in its history. They also initiated a national program on rehabilitation of persons with disabilities to provide rehabilitation through state governments to people with disabilities in their home. The community approaches to handicap in development focused on changing the negative attitudes of society towards people with disabilities to be more positive. Community-based rehabilitation is a 4-tier process, being comprised of Tier 1, the funding agency, Tier 2, the national coordinating agency, Tier 3, the project implementing agency, and Tier 4, the project coordinator. The community-based rehabilitation implementation process is organized into stages consisting of the selection of a project area and the appointment of implementing agency, the training of staff, surveying community residents to identify who has curable and incurable eye diseases, making referrals for medical treatment of those with curable diseases, the provision of training in social integration, and the separation of the incurable persons into educable children below 8 years of age, the economic rehabilitation group, and the social rehabilitation group. The services for the children below 8 are delivered by itinerant teachers and include school admission, pre-Braille activities, and counseling. For the economic rehabilitation group, the services given by field workers consist of family counseling, the identification of a trade, training and support services, launching grant monies for starting a business, and securing a subsidy if needed. For the last group, the training is done by field workers and involves family counseling, healthcare, and pension registration. The role of the rehabilitation field workers is multifaceted. It ranges from the identification of individuals with visual impairment, assessment of the individual's needs, the development of an individual rehabilitation plan known as an IRP, making referrals for appropriate services, alerting individuals with disabilities about their eligibility for concessions such as a bus concession, railway, disability, pension, or scholarship. The teaching of activities of daily living or daily living skills and vocational skills, and the documentation of services provided to advocacy for their clients. The field workers must come from rural areas, have completed high school, and want to work with people with disabilities and be articulate. On-the-job training is provided by the agency providing the community-based rehabilitation to the workers, which in many cases is the non-government organizations. The individual rehabilitation plan is an important component of the rehabilitation process. Being client-centered, the plan is developed after the client is assessed by the rehabilitation field worker in conjunction with the client and his or her family. The individual rehabilitation plan contains demographic information regarding the client, ophthalmic reports, the nature of counseling, the training needed, the vocational goals and training, and other services required for the client to become independent. You can think of the individual rehabilitation plan as a contract between the agency and the client, stating the roles and responsibility of each party. After a person with a visual impairment has learned a marketable skill, he can apply for financial assistance to start his own business. The financing is available through a bank loan, a loan from the Ministry of Social Justice and Empowerment's National Handicap Finance and Development Corporation, a subsidy from the Integrated Rural Development Program, state welfare departments, development agencies for the blind such as Sight Savers International, service clubs like Lions or Rotary clubs, and private donors. Another important aspect of community-based rehabilitation is self-help groups or support groups. Mosey and Golumbowski, in their article, Fostering Self-Help at a Distance for Adults with Vision Loss, in the Journal of Visual Impairment and Blindness, discuss the benefits of support groups for people with visual impairment. They mention that research has shown that people with visual impairment involved in support groups were more successful in coping with their visual impairment, had increased satisfaction with their level of activities, and had a more positive outlook on life in comparison with those individuals who did not participate in support groups. Similarly, Wise, in her chapter, Self-Help Groups for People with Vision Loss, and Susan Greenblatt's book, Providing Services for People with Vision Loss, a Multidisciplinary Perspective, cited the benefits of joining a self-help group as learning how to deal with problems and needs, developing coping strategies, acquiring a feeling of empowerment or control over one's life, combating isolation and alienation, developing networks, using time productively, and getting to know other people with the same condition. Weiss concludes by stating, quote, individuals with vision loss have embraced the concept of self-help as a valuable exchange of practical information and emotional support. End of quote. People with disabilities, including those with visual impairments, have formed support groups which have enabled them to become politically active on a local, state, and national level, advocating for legislation for the betterment of their lives. In some cases, they have been able to use the support group to organize a business and to seek funding for startup costs. Now let's look at a case study to illustrate what I've been lecturing about. Mohammed is an 18-year-old man who has just completed his 6-week training course to become a community-based rehabilitation field worker. He is from a small village and he has been assigned the cluster where he will work. Luckily, this cluster includes his home village. His first task is locating people with disabilities in his cluster. Mohammed decides to visit the village schools, talk with the opinion leaders, and make and post flyers at the next religious festival, which will be in 3 weeks. To be absolutely certain he locates everyone with disabilities, he has decided to visit every home in this cluster. On the first day of his home visitations, he is introduced to Manoj, an 8-year-old deafblind child who is a real handful for his parents. Manoj seems to communicate his needs to his mother and his 3 sisters through gestures. He cannot dress, feed, and bathe himself and has frequent outbursts, probably due to his needs not being met. Additionally, he has not been to school. Mohammed decides to make a referral to an ophthalmologist to obtain an accurate diagnosis of Manoj's visual condition and to an audiologist to see how much hearing he has, if any. The medical reports state the cause of Manoj's hearing and vision loss is Usher syndrome, where he has a profound hearing loss and his incurable eye condition is retinitis pigmentosa. Mohammed then discusses with Manoj's parents what Usher syndrome is, what the prognosis is, and what their goals are for Manoj. Mohammed tells them about people with deafblindness who are employed and about a non-government organization which has a school for children with deafblindness, which is 3 hours from their village. After consultation with the parents, Mohammed arranges a visit for Manoj's parents to visit the school, or the NGO, non-government organization. They are very happy with the program they see. Within 3 months, Manoj is heading to the school to start his education. As directed by his field supervisor, Mohammed documents daily in his diary his interactions with Manoj and his parents and his activities related to Manoj's case. Everyone is excited to hear about the progress Manoj will make at his new school. Mohammed's job stops when Manoj enters the school setting as a teacher of the visually impaired starts at that point. Now let's move on to the role of the educational professionals in rehabilitation, specifically the teachers of students with visual impairment, meaning you. Your role is to access, develop, and implement a program of study to assist the general educator to teach students with visual impairments to become independent members of society. In India, the teachers assist in the admittance of children with visual impairment to the formal school system, identify children with visual impairments, and make referrals for medical services. According to Panini, Raul, and Sajid, other responsibilities include 1. Mobility and Braille teacher. 2. Instructor of activities of daily living. 3. Teacher consultant to the classroom teacher. 4. Investigator for identifying the visually impaired children in the assigned area. 5. Promoter of the idea of the integrated education and complete integration of visually impaired children. 6. As an artisan, he is expected to train visually impaired children in various local trades and crafts. 7. Career counselor to the parents and the fellow students. 8. Organizer of foundation course for the classroom teachers. Together, the educators and the rehabilitation professionals can ensure students with visual impairments receive the medical intervention they need. are aware of education and rehabilitation services and government benefits they are entitled to, community-based rehabilitation services, counseling for the individuals with visual impairments, their families, and the community about the capabilities of people with blindness and low vision, the need for community integration, political activism advocating for equal rights and access of people with disabilities, and gainful employment for people with disabilities in their home communities. Monitoring and evaluation are also important aspects of the community-based rehabilitation model. The monitoring occurs at the field level, the implementing agency level, and the funding agency level. At the field level, the specific data that is analyzed is the results of the door-to-door surveys, vision screening documents, case files and assessment forms, diaries of caseworkers, client performance sheets, and attendance sheets. Evaluation data used by the implementing agency includes summary of vision screenings, the baseline data of people with visual impairments, weekly visit reports and review meetings, the case completion reports, and a physical performance register. Reports for the funding agency include the monthly physical performance reports, financial statements, and the project completion reports. Performance indicators used by the evaluation teams to rate community-based rehabilitation programs include understanding the concept, the extent of training activities, acceptance of the community-based rehabilitation concept by the project implementing agency, the cost-effectiveness of training, the components of training cost, the administrative structure of the implementing agency, and the extent of the acceptance of the community-based rehabilitation concept. Other performance indicators consist of the financial spread of the coordinating agency, the level of sustainability of the concept, the sustainability of the organization, the transparency of operations, the justification of capital investment, the source of funds, financial viability of training activities, the retention and quality of staff, the possibility of support from other sources, the extent of support from government, the development of social communication, exposure of community-based rehabilitation to the worldwide community, and the credibility of organization and people. The challenges faced by the rehabilitation field are many. A large number of people with visual impairment still need to be served. A lack of monies and personnel to provide services exists. Adequate training of personnel needs to still be provided. And the attitude of employers and society toward people with visual impairments requires changing. The good news is that the community-based rehabilitation model is still working and is being implemented worldwide. In conclusion, the important points to remember from today's lecture are: 1. Community-based rehabilitation is a goal-oriented, need-based, cost-effective, and results-oriented strategy of providing time-bound and appropriate services within the community, with its active participation, involvement, and with fullest use of its resources. 2. Community-based rehabilitation is a model that is used worldwide, especially to provide rehabilitation to developing countries like India. 3. Historically, the call for rehabilitation programs to be offered in rural areas was made in the 1950s. 4. Most people with visual impairment in India are living in rural areas, are older, and are women. The leading causes of blindness are cataracts, trachoma, and vitamin A deficiency. 5. In India, rehabilitation centers are few in number, expensive to operate, and are usually located in urban areas, thus not meeting the needs of the majority of adults with visual impairments who reside in rural areas of India. 6. There are prerequisite skills for students with visual impairment to gain prior to their involvement in a rehabilitation program. 7. The components of community-based rehabilitation include covering people of all ages, be cost-effective and result-oriented, be realistic and need-based, be in consonance with state policy, include aspects of prevention and cure of curable disability, certification of incurable disability, social integration, integrated education, economic rehabilitation, support services and concession, advocacy rights of persons with disabilities, act as a pressure group for influencing state policy, community empowerment and participation, and the utilization of community resources. 8. The characteristics of community-based rehabilitation are centered on the integration of community-based rehabilitation services into existing networks such as healthcare, education, and developmental services. 9. Rehabilitation workers and educators collaborate with one another to identify children with disabilities and to provide appropriate referrals for medical care and education. 10. Once a child with a visual impairment is in formal school setting, then the rehabilitation field worker's job is done and the itinerant teacher of a student with visual impairment takes over. 11. Monitoring and evaluation of community-based rehabilitation must be carried out on a regular basis. Specific evaluation indicators are suggested for an evaluation team to review. I hope you have gained some new information today concerning the rehabilitation process used in India for persons with visual impairment that you can use in your work with the students you teach. Thank you for listening.
You were listening to the audio program Community-Based Rehabilitation for Persons with Visual Impairment. The subject expert and speaker was Dr. Nora Griffing Shirley. Announcer was Gautam Malviya. This program was recorded, edited and presented by Amar Bahadur Yadav. This was an audio production of the Electronic Media Production and Research Center EMPRC of Madhya Pradesh Bhoj Open University.